Hey everybody, it's Dr. Scott Worden, the TOS guy. Today, we are live streaming from beautiful but rainy Santa Rosa, California. I wish I could show you outside. The river here is flowing and the grass is green and it's cold and wet. But I'm happy to be here live stream. Today, we're going to start with 5 common questions about TOS. Question number 1, what is thoracic outlet syndrome? To define thoracic outlet syndrome, it helps to define the thoracic outlet. The thoracic outlet in humans is the side of the neck. On each side of the body, we have one thoracic outlet. This is the area you can feel over your clavicle or collarbone. It starts with the boundary being the neck and the spine. It crosses over the chest and the lung, and then enters the shoulder. And through each thoracic outlet, we have 3 vital structures that have to pass. First, we have the subclavian artery. This carries fresh oxygenated blood from the heart and lungs through the thoracic outlet on each side to enter the arm. Then once the oxygen taken out of it and the waste products added, it comes back in the veins. These veins coalesce to form the large subclavian vein. On each side, the subclavian vein leaves the arm, enters the thoracic outlet, and returns to the heart and lungs. And then the third vital structure is the brachial plexus. This is a cluster of 5 nerves that forms within the spinal cord, leaves the spinal cord, passes through the spine into the thoracic outlet, and then into each shoulder. Now, the nerves send signals and receive signals, so it goes both ways. Well, any structure or dynamic change that compresses or stretches or damages any of these 3 structures that results in symptoms is the definition of thoracic outlet syndrome. So in other words, you can get arterial compression, which damages the artery wall. And this results in blood clots forming, and we'll get into this in just a little bit. The next thing is, what are the main symptoms of thoracic outlet syndrome? What are the symptoms of thoracic outlet syndrome depends on which structure is being affected in the thoracic outlet. Let's start with the arteries. The most rare form of thoracic outlet syndrome is the arterial form of thoracic outlet syndrome. And this is where the artery is damaged, usually by very turbulent blood flow damaging the wall. And since the artery is under high pressure, the wall can balloon into an aneurysm. Less commonly, it can form a scar or a stricture or a narrowing. But the most typical form of arterial TOS is where an aneurysm forms and a blood clot can form within that aneurysm. Now, the blood clot may grow and block the artery, or it may break off and travel downstream and block smaller arteries. Once you use this, you see this procedure and you see the blood clot blocking the blood flow to a part of the arm, that part of the arm is in danger of dying or gangrene. So we don't see at Vanguard Specialty Imaging cases of arterial thoracic outlet syndrome because they usually go to an emergency room and they're usually treated emergently by surgeons to remove the blood clot and restore blood flow. Now, when the veins are affected, we usually get this by forming a blood clot within the large subclavian vein on each side. Now, the blood pressure in the veins is much lower than that in the arteries. So what happens is the patients will have a swollen arm that changes color, often a deep blue or purple. The blood cannot return from the arm back to the heart and lungs. And so the patient gets a heavy arm that's swollen. They'll see new veins form over the chest as the body tries to adjust. We don't see many of these cases either, because typically, while not as emergent as an arterial blockage, the venous blockage is still treated by surgeons in an emergency room. They try to remove the blood clot, and then later they'll treat the damaged part of the vein and try to remove the structures that damage the vein to start with. Now, by far the most common type of TOS is the neurogenic type, where the brachial plexus is involved. And symptoms here vary widely. So patients with neurogenic TOS will often get a wide variety of symptoms that may include some or all of the following: numbness, tingling, anesthesia, where they can't feel a certain part of their skin, dysesthesia, where something pleasant feeling starts to feel badly, hyperesthesia, where something as light as a cotton shirt can be irritating to the point of pain. They can experience weakness of grip strength in either or both hands. They can get discoordination where they can't use their fingers the way they used to before. They can often get a deep aching sensation. It's not typically a sharp knife-like pain. The symptoms can occur in all parts of the arm. Typically, it's bilateral. Typically, it involves the forearm along the little side of the finger. So where your little finger and ring finger are located, those fingers can be involved. That side of the forearm can be involved as well. That's a classic spot, but all parts of the arm can be affected. In addition, there's a typical pattern of pain and relief. Oftentimes, people who get neurogenic TOS get it because they work with a bad workstation, where they do repetitive work with their arms in front of them or overhead. So oftentimes they'll report that after work they have symptoms, but the symptoms improve at night. Then they start the next day near the end of the day and improve at night. But as the condition worsens, the pain may last overnight, and eventually the patients won't even get improvement over the weekend. So they end up having permanent pain of varying degrees that may be better or worse depending on whether they are partaking in the inciting activity. Remember that since there are 5 nerve roots that make up the brachial plexus, we have a broad area of the spinal cord that can be affected. So again, the symptoms can involve anything from the chest and headaches out through the entire arm, or just a small part of that. In neurogenic TOS, this is what makes it a diagnostic challenge. Third question that's common is, what causes TOS? So as we mentioned, when you get symptoms from compression or stretching or damage of any of the 3 vital structures, that is what we call the definition of thoracic outlet syndrome. I break the causes into 2 types. I call them static and dynamic. The static types would be something that a person is born with. For instance, a cervical rib, which many people know about, that can take up space that the arteries need. And it's more common to see a cervical rib associated with arterial TOS than with other types of TOS. But patients can also have an abnormal first rib that they're born with, an extra muscle, such as the scalene minimus muscle, or the scalene muscles may be normal where they arise, but when they insert, they may be too broad. They may overlap, narrowing a tunnel that the nerves, the artery have to pass through. So these are the things that people are born with. We call them predisposing because patients are born with these and don't develop the symptoms until later in life when they do something that stresses the area. Then we have the dynamic causes. When you move your arms, the ribs tend to stay in place, including the first rib, but the collarbone and the shoulder blade move a lot. Now, if they move into the wrong direction, then they can cause narrowing between the collarbone and the first rib. That's one of the common areas where we can get compression of the nerves, the arteries, or the veins. But you can also have abnormalities in the scalene triangle or in the retropectoralis space, where this neurovascular bundle, meaning nerves and blood vessels, have to pass through to reach the arm. So in general, we look for signs of compression of the nerves. We look for loss of fat around the nerves. We look for areas where the nerves might be stretched. For the arteries or veins, we look at the typically round cross-section becomes oval because they're being compressed. And then we look for secondary signs like an aneurysm of the subclavian artery, or a stricture or narrowing within the subclavian vein, or a blood clot within either of these structures. How is TOS diagnosed? Well, the first thing is the doctor would ask a patient and get a history, and hopefully the doctor recognizes that that unique history sounds like TOS. That's not diagnostic, but it's a clue in the right direction. Then hopefully the doctor would perform specialized provocative tests, not just a standard neurologic examination, which does not see TOS, but specialized provocative tests to position the arms and the neck to reproduce the symptoms. You may have heard of a test called Adson's test. This actually tests the blood flow through the scalene triangle, but it's not a great test for looking at nerve compression. If you suspect arterial TOS, of course, that might be helpful. But since neurogenic TOS is the vast majority of cases, Adson's test is not a great test to start with. There are better tests such as the Ruse test or the upper limb neural tension test. Nonetheless, when a doctor performs the correct provocative test, especially for neurogenic TOS, to a lesser degree for the venous or arterial types, the answer may help point towards TOS, but none of these clinical tests is highly accurate. They're just a suggestion and should be followed up. What should they be followed up with? Well, obviously, in my opinion, imaging, because none of these tests shows the exact anatomic point that's causing compression or stretching or damage of the 3 vital structures. So imaging can do that, and the imaging in combination with the clinical findings is right now our best way to diagnose TOS. A side note, many people and many insurance companies insist on getting an EMG. It's actually part of a test called the electrophysiologic testing, EMG, and nerve conduction studies. But these tests most often are normal in patients with TOS, so they don't rule it out or rule it in. Even in cases where they're abnormal, they don't show any of the anatomy or show where the nerves are damaged. They may add a little evidence, but really it's not a very useful test. Once you have the clinical findings and the imaging findings, EMG or electrophysiologic tests are not very helpful. Can TOS be treated without surgery, and what are the best options? So in the medical literature for many years now, it's been stated that about 10% of patients with TOS go to surgery. I'm not so sure that those numbers hold up. What I can say is that the dogma in general, even among surgeons, is if you have TOS, you should undergo conservative therapy, like physical therapy, for 6 to 12 months before you get to surgery. Now, there are other papers out recently that show that patients do better if there's a shorter time between diagnosis and surgical treatment. Right? So we want to find the patients who do need to go to surgery and treat them faster and not stall them with 6 to 12 months of conservative therapy. But we want to find the patients who don't need surgery, and there are a lot of them, who need to get the right therapy beforehand, and we need to stick to that for a proper amount of time to allow them to get better. So one of the mainstays of this is physical therapy, briefly mentioned. And we know several people who are specialized in TOS physical therapy. This is important. Just like you wouldn't see a specialist who doesn't know about TOS as a doctor, you want to find a TOS specialist doctor. The same thing goes for physical therapists. They're like people who have experience and a good track record and have a dedicated plan. It usually does not include strengthening in the beginning. It includes things you may have seen on our videos with Steve Talakowski: relaxation, biofeedback, changing posture, improving breathing. But rest is an important part of it to allow the nervous system to calm down, including the central nervous system, the brain, to start perceiving pain in a different way. So physical therapy is a big part of it. Then what I roughly call occupational therapy, if you have a non-ergonomic workstation, or you have a job that requires you to work with your arm in an unusual position or your neck in unusual positions, we want to correct those things, give you the best tools, and correct the bad motions. Third, some people use drugs, standard pain medications, up to and including opioids in many cases for severe pain. There are nerve agents that calm the nerve membrane, nerve stabilizing membranes, such as gabapentin you may have heard of. So there are a few categories of medications that can help. And then fourth, we find that recently over the past decade to maybe 15 years, some people have become more proficient in performing selective injections. This could be a whole talk by itself. But generally, people will take an ultrasound and guide a needle into a muscle or around a nerve, and they'll inject, in most cases, either a local anesthetic or a longer acting agent like Botox. Now, done diagnostically, you could theoretically inject one muscle with a local anesthetic. Lidocaine can have an onset in 5 to 10 minutes and last for 30 minutes or 40 minutes. But if you have a positive result where the patient notes an improvement, then that's diagnostic. It's not meant to be treatment or to change the problem, but to prove that that muscle is contributing, is a pain generator, at least part of the problem. Or some people do what's called hydrodissection around the nerve roots, where they inject a medication and they try to loosen up the nerve so it's not scarred or trapped. Then recently we've been hearing just a little bit about people doing cryoablation, which is where they freeze small nerves and the nerves take a few months to regenerate. But in the meantime, the patients can have reduced pain. This is where something such as Botox comes in, because Botox can last for 3 to 6 months if it's used properly. Now, one issue is that if you start with local anesthetic injection, Botox is not guaranteed to work because it works with a different mechanism. We don't know yet why this happens in some people. They respond to local anesthetics and Botox, where other people respond only to local anesthetics and not Botox. Nonetheless, some people have used Botox because it's longer acting to allow for an improved and more intensive physical therapy course. So yes, it can be treated without surgery, and in many cases, TOS is treated without surgery. But I believe that imaging and understanding the exact pathology in each patient is important to dividing up those patients who need to go to surgery more quickly and those who need a good, solid, persevering course of conservative therapy. Now we have one more, a bonus question, number 6. Is there hope for recovery from TOS? The answer is absolutely yes. I can tell you in the short time I've been doing this, about 25 years, we've seen really a sea change. Number one, more doctors are recognizing the disease, and that means patients are getting to specialists like us and then going to specialty imaging sooner. And that makes a big difference for patients. Once you get chronic pain and your brain settles in and it adjusts to the chronic pain, it's harder to turn that around. So we're seeing patients younger. We're seeing patients earlier after they get symptoms. And this is a good thing. I believe imaging has advanced. I believe the selective injections have advanced. I believe teams of doctors working together, like colleagues of ours who work at Emory or at Massachusetts General Hospital, with a multi-specialty team, are making a bigger difference than the single vascular surgeon used to make in the past. So yes, there absolutely is hope. There's hope for recovery from TOS. And we urge you a couple of things. Reach out to us on our homepage. You can find a contact us button at the top right. We help a lot of people that don't get our scans, but we get them to right specialists and we get them good consults and give them a good 30,000 foot picture of where they are. Next thing is, please help us spread the word. You can hit the like button and you can subscribe to us here and hit that little bell button so you hear every time we have a new talk coming out. And next, I'm going to take questions, but I want to remind people we have a special guest on March 17, Dr. Harvey Chim, who's now at LSU, is very experienced in TOS and learning a lot, and very smart guy. And we're going to be talking about rib sparing surgery. We actually do surgery, but do not take out the first rib, which is the classic and accepted way of treating this. So there's a lot of promise in this technique, and Dr. Chim is going to do a great job explaining to us how this makes a difference. Now, do we have questions that we can answer? Thanks, 22 Tate. Good to see you again. Wondering if you can speak about some of the more surprising symptoms of TOS and what meds might be of help. So TOS, neurogenic TOS, can have a number of unusual symptoms. A couple that I didn't mention or didn't emphasize would include headache. Headache is very common among patients with TOS. And we feel that maybe due to some of the fascial planes shifting may affect these small areas where the occipital nerves go through. We also believe that in patients with neurogenic TOS, we'll also have vein compression, that the abnormal blood flow returning from the arms and the head and neck can cause congestion. That would be like if you wrapped a blood pressure cuff around your arm and you didn't loosen it completely. The arm distal to that would just be slightly swollen. And once it stays that way, it creates its own problems, including more nerve damage. Then some patients actually get extra sweating. Some patients get color changes in their hands at unexpected times. And we do find that some patients get lower extremity symptoms. We believe are associated with TOS. I'm not going to go into the mechanism now, but Dr. Newkirk, who's retired a while ago, has for decades seen patients with lower extremity symptoms without a solid explanation. None of it is proven, but yes, I'd say 10% of patients, we also see lower extremity symptoms, and we believe they're related to venous congestion. Thank you for that good question. Hey, here's a new guy, 22 Tate. Is it possible to have venous TOS, but over time have the symptoms change and become more typical of neurogenic TOS? That's an absolute yes. So venous TOS has a different mechanism. It's really in a different space than the nerves are. So something may compress the veins earlier and more seriously, but as you change, as your body changes and you adapt to that, in other words, you guard and hold your shoulders and neck in different positions to try to reduce your symptoms, that may encourage the posture of body to change enough to narrow the different areas where the nerves go through. Additionally, we believe, and there's evidence for this in the literature, that chronic congestion, meaning that the veins do not drain enough over time, leads to chronic swelling of the arms and chronic, slow, progressive nerve damage. So that may contribute to neurogenic TOS as well. Previous talks we've had with Dr. G from Florida have centered around this, and he actually focuses a lot on resolving venous compression to prevent that kind of nerve damage. That's a good question that we go really into depth into. Maybe we'll do a separate talk on that. Thank you. How common is bilateral TOS? Yeah, it's a good question. I would say it's very common. I think that the people who have the anatomic background or predisposition to TOS tend to have it on both sides. We rarely see a difference between the two sides. We have a lot of data on this. It's rare. One patient may have a wider costoclavicular interval than a second patient, but both sides will be wider and both sides will be narrower in the narrow patient. So we do see patients who present obviously with bilateral TOS. That's an easier diagnosis to make because there are a few things that could cause that kind of symptom complex bilaterally. When you have a unilateral patient, sometimes it's slower to a diagnosis. But what we'll find with those patients is after they get treated, they start noticing symptoms on the other side. And so what we believe happens is their first side improves, they get more active and go back to a normal lifestyle. And now that stresses the other side and creates symptoms. Or that they really had symptoms on both sides, but the predominant side was just too much and masking the other side. So they just didn't really see it because the pain was too much on one side. And I'll also say that anatomically, I will often see a patient with unilateral TOS. And when I image them, the other side has similar bad findings where I would swear that they have symptoms. Obviously, an MRI doesn't show symptoms. And these anatomic findings are a predisposition to getting the disease, which needs the superimposed activity or abnormal posture. But I would not be able to tell the difference between the painful side and the non-painful side because they're both abnormal. Thanks. That's 3 good questions in a row. Next time I'll have to hand out prizes. All right. Can you speak briefly about the role the scapula plays in TOS? So the answer to that is no, I can't speak briefly about it. It's very involved. It's a good question. The scapula may be the starting point for everything. What we've seen from what's in the literature, and it's mostly orthopedic literature that covers the motion of the scapula. As you might imagine, baseball pitchers, they study the rhythm of what's called scapulohumeral rhythm, but how the bones of the shoulder move together. But a lot of it centers around the posture of the scapula, shoulder blade. I also remember what I mentioned before, there are 17 muscles attached to the scapula, several of which adjust its position relative to the chest wall. There is no bony joint that holds it in one place. There's just a swivel joint where the shoulder blade meets the collarbone, and then the collarbone has one swivel joint where it meets the breastbone, sternum. So there's a lot of motion, 6 degrees of motion of the scapula, and depending on the balance of the muscles, you will get different positions of the scapula, and that means different positions of the collarbone, which means different spaces of the thoracic outlet where you can get narrowing or stretching. So scapula is super important. We have a proprietary method that we use to measure the shoulder blade position in every patient that we scan. Arms at rest, arms up, arms comparing side to side in either position. And so we can find asymmetries in that. A good clinical exam, which doesn't occur in every doctor, includes looking for scapular winging, both active when you're pushing on something and passive when you're just standing. Is there a difference between the scapulae? Do they protrude from the chest wall? So your doctor should look for that. Again, shout out to the guys at Emory. They spend a lot of time looking at scapular dyskinesis, and we believe that that contributes to TOS, in particular, Pec Minor syndrome. The way it's described in the literature now, I don't agree with the definitions at all. I think it's associated with the Pec Minor being abnormal. That's one of the muscles that attaches to the shoulder blade. So when you do a selective injection into the Pec Minor and you get positive results, that may often be because of scapular dyskinesis. So I'm going 5 different directions here for a reason. It's complex. It's a great question. I'd love to talk about it forever, but the word briefly is hard to make fit with this. So thank you for a good question. And that's another one we should probably do a whole talk on. Thank you for the question. Same user. You mentioned a static cause of TOS being an enlarged scalene muscle. Can this be identified in an MRI, or is this only discovered during surgery? So a good question, and I skimmed over this because this is a broad topic. Yes, we can see an enlarged scalene muscle on MRI. We can compare side to side. That's one way to see it. Or if you have a lot of experience like I do, you start to see the muscles and you understand how big they should be, and you can make the good judgment whether it's hypertrophied or atrophied or normal size. You also, though, look for its origin, because frequently the origin is not clean. It arises in a normal situation from 3 or 4 different little tubercles of the cervical spine of tiny bony processes, and so does the middle scaling separately. What happens is that oftentimes these muscles don't originate separately. There's just a big, common, complex mass of muscle at their beginning, and the nerve roots have to kind of find their way between these muscles. So the muscles are wrapped around the nerves instead of it being two clean, separate muscles that you might see in a medical illustration. Then we have the insertions, where they insert on the first rib as a fibrous insertion. And sometimes those insertions are pretty big and they can overlap even, which then creates kind of a sharp edge of a tendon that lifts up the neurovascular bundle and actually indents it. We've seen this on some surgical reports in some papers in the literature. So those things occur. And then finally, there is medical evidence showing that the muscles can be internally abnormal at the electron microscope level, where they have too much fibrous tissue, almost by double, and they have a big shift from the fast twitch fibers to the slow twitch fibers. So the muscles after trauma are known to change. That part we can't see on MRI. So we can contribute, but we don't cover 100% of what could be abnormal. That has to be based on some of our knowledge from the literature and the physical examination. Certainly at surgery, surgeons can palpate the muscle and feel how tight it is. They can't judge the electron microscopic nature of it either. They can send it to pathologists if they want, but I don't think that's done commonly. They just view it as a space occupying structure and they remove it and free up the brachial plexus. Thank you. TAMS 1212. Hi, Dr. Worden. I'm getting a brachial plexus MR neurography and a cervical spine MRI, I presume, 3T. That's a stronger magnet. I would like to send my imaging report to you after I get this done and have you go over it. I live in Canada. We do some imaging consultation. In some cases, please reach out to us on our contact us page and we can discuss those details with you. A couple of quick words since you brought up the MR neurography. I do not think it's a good substitute or an isolated substitute for a good dedicated TOS MRI. The literature on it doesn't really show the sensitivity of it. I think the nerves, from my experience, can be abnormal intrinsically without looking abnormal on MR neurography. I think it's something radiologists love to have because it's pretty images. But please remember that TOS is a disease caused by the structures outside of the brachial plexus. By definition, the plexus starts normal and it becomes abnormal because of the extrinsic structures that stretch or compress it. So those structures have to be seen, and MR neurography does not show those. Getting a cervical spine MRI is good depending on your age. If you're very young and very unlikely to have disc disease, then cervical spine probably isn't that helpful. We do, on our studies, always check the cervical spine, and we include it in our protocol because just in case somebody has a herniation that could mimic TOS, we get it. But it's unlikely with a good clinical exam to have cervical spine disease mimic TOS. A good clinical doc should be able to do like a Sperling test and check for spinal stenosis or neural foraminal stenosis, really, versus TOS. And thank you for the question, and please reach out to us. Same person. They do not have much knowledge here. I know it would cost me. I'd like to have the images looked at by a professional, and I've been living in pain for almost 6 years. We definitely want to help you. And so part of that might be to get you to a good TOS specialist, like a video chat or an in-person visit, which is an essential part of it. It's not just imaging. We never say that our study is the be-all and end-all. Without a physical exam and a good specialist, it doesn't have as much value. So let us help you. Please reach out to us on the contact us page. Thank you. A gaming car 907. I love usernames like this. I'll spend all night trying to figure it out. Number 6 was my question. I really want to return to weightlifting, driving, and life without pain. I will remain hopeful. Thank you, Mr. Worden and Mr. Rep, for these great talks. We really appreciate people attending and asking questions and participating. Thank you. And just help us spread the word. Give us a like, subscribe, hit the bell button, and tell the other people that you contact with TOS to reach out. We're always happy to help whoever we can. Can you discuss the expertise or lack of expertise that a radiologist who does not specialize in TOS has when reviewing an MRI of the brachial plexus with contrast with provocative movement? Yeah, so I'm not going to step on anybody's toes if I can help it. I think like everything we do as humans, especially the more complex, challenging stuff. Experience makes a difference. And our experience here is not just that I've read thousands of these studies, but I'm constantly wasting my nerdy OCD time, talking with doctors about what they do, the clinical doctors, understanding their questions, understanding the disease, talking to patients and understanding their different symptoms and what they find helps them or doesn't help them. Their success stories, how patients did get better by themselves or with help. So trying to combine all this knowledge, as well as I was board certified in internal medicine, so I understand the clinical side of it. All of these things we have to add together for this complex disease. It's really hard. If a radiologist hasn't done a lot of these, he or she may miss things. Maybe they'll see stuff. Everybody learns gradually over time, but we have a lot of faith in what we do, and we understand how difficult the disease is for patients. So I can't name you another radiologist I know who's a specialist in this, probably because to us, it's a little corner of the world, but to me, it's not. Probably because I'm OCD, and partly, to tell you the truth, as I talk to patients, I realize how important, Herb Rep and I are to helping people, and what we do, provide a service we sincerely believe helps a lot of people. So, I think it's expected that some docs will be less specialized than others in this. Come to us, we do our best to help. Thanks for participating. Judy D. Amarillo. I have symptoms of TOS, but I've also had previous CTs or carpal tunnel syndrome in 2018. Didn't bother till 2025. Can this just be TOS because they want me to have surgery on CTS? I think that's what we're asking. Clarified if I didn't get it right, and I apologize. So carpal tunnel syndrome is oftentimes seen and treated, and then patients get recurring symptoms because there's a condition called multiple crush or double crush. If you compress a nerve proximally, like up in the shoulder or the thoracic outlet, the distal part of the nerve is sensitive, and a normal level of compression distally can cause symptoms, even though it's not enough by itself. So because the nerve is too sensitive, it overreacts. Example, you have thoracic outlet syndrome, no one's diagnosed it, but you have what looks clinically like carpal tunnel syndrome. It's, in this case, a combination of the nerve being compressed in the thoracic outlet, the nerve being too sensitive the rest of its course, and then low pressure on it in the carpal tunnel mimics carpal tunnel syndrome. You have the carpal tunnel release under surgery and you feel better, and then 4 weeks later, 6 weeks later, the pain comes back and now it's more proximal. That is not an uncommon story. I think most good hand surgeons who diagnose carpal tunnel syndrome will check, at least superficially, that there's nothing more proximal causing this problem. So I would look up and read a little bit about multiple crush or double crush to understand how this works if I'm not explaining it well. The carpal tunnel syndrome surgery, oftentimes it's the right thing. No question there, but just make sure your doctor checks that there's nothing happening more proximally. Thank you. The same user joining us. TOS neck, shoulder scaling, and pec muscle pain, numbness and tingling in both hands, cervical stenosis, bilateral rotator tear, carpal tunnel syndrome. Could this be a combination or originate from thoracic outlet syndrome? Number one, I can't answer specific medical questions for your case, not in this format, but please contact us. In general, if you have bilateral hand and finger pain, especially if it's the little finger and the ring finger, that will lean more towards TOS than towards carpal tunnel syndrome, which would affect the thumb, index finger, and long finger preferentially. Now, the median nerve that causes these symptoms of carpal tunnel syndrome can be involved in thoracic outlet syndrome. So even then, if you have some involvement of the thumb, index, and ring finger, it could still be TOS. It sounds like you may still need some separation because you mentioned scaling pain and pec muscle pains. I don't know if you mean pec minor or pec major, but those are unlikely to occur with simple carpal tunnel syndrome. So at least get a second opinion before surgery does carpal tunnel surgery, and you should feel free to bring up that it might be TOS and what do they feel about that. And contact us where we can help you with more specific, personalized medical questions. Thank you. What other type of imaging is good to get if things don't show up in an MRI? Well, ultrasound has some uses. A CAT scan can show some of the things that an MRI can. Again, we've had this situation come up. We don't always find it helpful to read other people's studies. We've done it in certain situations. The technique that they use may not allow a proper interpretation, but sometimes it can be helpful. So that's the type of thing that we should probably talk about on a consultation if you reach out to us. In general, as general questions, again, not to you personally. Ultrasound is real time, so you can watch things move. It doesn't separate the nerves and muscles great. It doesn't show really the costoclavicular interval very well because the bone shadows the ultrasound. It does show blood flow very well, but if you have neurogenic TOS, the blood flow is less important. Even complete compression of the vein doesn't mean you have neurogenic TOS. So ultrasound is somewhat helpful, but it has to be done in the right hands. It's much more sensitive to the technician performing it. There's this huge degree of difference between beginners and experts, and even experts may not be expert in TOS. So you'd really have to find the right person or the right clinic. A shout out to Johns Hopkins. They do very detailed vascular ultrasounds there for TOS under Dr. Yingwei Lum's direction. However, it's not always the answer in neurogenic TOS. CT scans that you brought up don't show the soft tissues nearly as well as an MRI. And a lot of soft tissues cause these problems in TOS. We hear about cervical ribs, but I'd say less than 1% of our cases have surgical ribs. And it's the soft tissue abnormalities that are much more important. So MRI is better for that. CT does show the bones very well and the arteries and veins very well. Very stark, white, clean, and clear. So it's easier for a surgeon to see because surgeons don't see as many cases as I do, and they don't see all the little shades of gray. That's my job. But it doesn't show the soft tissues as well. So each one has some advantages. CT you have to use radiation for, so we tend to shy away from that because it uses radiation and because it doesn't show the soft tissues as well, including the brachial plexus. So I hope that's a start. Thank you. Stacy Lynn Garcia. Hi. Any TOS specialist you recommend in Orlando? Two of the specialists you've recommended no longer practice or moved away. Or any good physical therapist in Orlando. No, I don't know a good physical therapist right now. We're still reaching out, looking for one. Dr. Chim, who's going to be one of our speakers, actually was in Florida. I think USF, but anyway, he's moved on to LSU. I don't know how far that is for you. Right now, I don't have someone besides Dr. Gargazlu and there's Michael. I have to look up his name. If you reach out to us, it can help. Now in Emory, which is not too far from there, yeah, there's a good team, which is Dr. Wagner, Eric Wagner, a surgeon, and Dr. Robbie Bowers, who's a sports medicine doc. And I think they have a very good team, young progressive guys who know a lot about TOS, and that's worth investigating. And again, we can give you the contact information and help you contact them if you want to reach out to us. So please go to our homepage at tosmri.com and look for that button at the top that says contact us. That's tosmri.com. I'm sure you all know that anyway, but I'm just going to push it again. Again, I want to remind you, please hit the like button, hit it really hard. Just don't crack your computer screen or the button's great, but hit like. That helps move up the awareness level so we can get to more people. And subscribe if you haven't already and hit the bell so you get notified. Are there other questions, Herb? Hi, Stacy Lynn again. Dr. Gargafo moved on. I think he's in California now, but he's also working a different non-clinical job. So he's not one you can see for TOS, sorry. All right. So those were great questions. We really appreciate their participation. I can't tell you how much it means to me to have people come and follow us regularly and to do their own work, obviously, to ask really good questions. Those questions allow us to discuss things that a lot of patients will see that you don't know about. So all of you who are participating, taking the effort. There are people who are going to see these videos in the future and get answers to their questions because you're digging so deeply, and we greatly appreciate that. We also want to remind you, March 17th, Dr. Chim, Harvey Chim, is going to be here really nice young guy, progressive guy, a lot of knowledge. I'm really looking forward to the talk on rib sparing surgery. And there's a lot of things that undergo that. Why do we spare the rib? And that'll deal a lot with the mechanism and the anatomy of TOS. So I look forward to that. Um, Follow us, please. We are on multiple social media channels. Reach out to us for questions that we can expand on further. If you have personal medical questions, we can't answer them here, but we love to do consults with the people who reach out. So for now, this is Dr. Scott Worden, the TOS guy in Santa Rosa, California, wishing you all a really great week, and thank you.